Now I like to present cholecystitis with triple vessel disease. Who goes first? Next. 60-year-old male patient, diabetic since 20 years, presenting with a complaint of right hypochondrial pain, and tenderness was also noted in the right hypochondrium. Ultrasound abdomen suggested acute calculus cholecystitis with chorioe perforation, bilateral mild pleural effusion, and grade 2 fatty liver. Subsequently, patient developed shortness of breath. TROP-T was positive. ECG, no ST elevations were noted. Angiogram was done and left main plus triple vessel disease was noted. Echo showed EF of 50% and grade 2 diastolic dysfunction, and ectopics were noted during the study. So these are the angio lesions, like left main 80%, LAD 90, diagonal is 90, LCX is non-dominant, and RCA is also 90. So this heparin was started after angio, 5000 units, IV 6th hourly, and CRP is 200 and serum creatinine is 1.1. Mild leukocytosis was noted. And the case was discussed with the cardiologist, cardiothoracic surgeon, and general surgeon. And now let us see who goes first. Open for panel. General surgeon or cardiologist?
I think again it's same like the previous one. From cardiologist point of view, troponin positive, but patient also has active infection of cholecystitis. First, of course, if it is a perforation, then I think we will not wait. So it would be simultaneous only, again similar to the last case, but probably again, as he has already said previously, we will open the abdomen and treat it first and then CABG.
Yeah, but what we did, I like to present. Because of high suspicion of perforated gallbladder and high inflammatory markers and risk of sepsis progression, high perioperative cardiac risk was explained and CT surgical team was kept on standby. Heparin was stopped, NPO status confirmed, and high risk consent obtained. And next, coming to all emergency drugs were kept ready in OT, cannulated, radial artery cannulated for continuous BP monitoring, IJV cannulated for CVP monitoring, good premedication induced with fentanyl and etomidate and maintained with O2 sevoflurane and vicuronium. Hemodynamics was stable throughout the procedure and surgery was uneventful. So patient was extubated on table, shifted to cardiac ICU after open cholecystectomy. And post-op pain was with Tramadol and paracetamol. Antiplatelets were started on post-op day 1, soft diet on post-op day 3, drains removed on post-op day 5, and discharged with ivabradine, metoprolol, clopivas. And after 3 weeks, CABG was performed. Anyone can? Okay. So next, one more case I like to present. This is a case 2, like patient 69-year-old female with diabetes mellitus since 25 years and hypertension since 25 years and thyroid hypothyroid since 5 years and CVA history 6 years ago, came with the complaint of right hypochondrium and epigastrium since 6 months, aggravated with food intake radiating to back, and is not relieved with proton pump inhibitors. Ultrasound suggested chronic calculus cholecystitis and 8.5 mm in the fundus and 4 mm in the body, focal wall thickening at the fundus, and patient was scheduled for laparoscopic cholecystectomy for general anesthesia, and the patient was referred for cardiac evaluation prior to the surgery. And echocardiograph revealed ejection fraction of 45%. Regional wall motion abnormality was noted in LAD territory, paradoxical septal motion, trivial AR, mild MR and mild TR, and mild PH was observed. As angio revealed triple vessel disease, we posted this case for CABG considering reduced EF, regional wall motion abnormalities, and after discharge we are planning for interval cholecystectomy. Key learning points were elderly diabetics can present with abdominal symptoms instead of chest pain. CRP 200 plus suspected gallbladder perforation implies severe systemic inflammation. Early cardiology and CT surgical involvement improves the outcome. And stop heparin before surgery and restarts antiplatelets as early as possible. Etomidate for hemodynamic stability and invasive monitoring. Avoid tachycardia and hypotension. TROP positive case have high morbidity despite no ST elevations. Once the abdominal source is controlled, definitive CABG is to be done. Thank you.
Yeah, ongoing ischemia, if 2-3 more millimeters ST depressions with this left main, the previous case you were talking.
First case, no ST changes.
No,
sir.
supposing there is, how do you manage? How do you protect the heart during your cholecystectomy?
T.
No.
Sir, if there is a sure shot type 1 MI where it is ACS related, it is a different scenario. Here is a non-ACS related, and I would like to, as a surgeon, I would like to stop laparoscopic procedure and consider if there is an ongoing, it is reversible, I'll consider open cholecystectomy rather than lap cholecystectomy. That is the first choice. We should know when to stop any surgery when there is ongoing ST changes. Okay, that is very important in this case.
Yeah, sometimes protection with IABP, NTG, controlling the heart rate with esmolol, something where you reduce the metabolism and improve the diastolic perfusion to buy time, may sometimes, yeah.
Like there is a supply-demand mismatch when there is a hypotension which has happened because of poor analgesia, poor anesthetic effect. If the patient has a predisposed already triple vessel disease, when there is hypotension happens because of RV dysfunction per se, if you don't give volume, there will be LV problems and the coronary ischemia and also. It has to be corrected, depth of anesthesia and all the factors to be considered.
Yeah, closed loop medication to protect the heart, both heart rate and NTG, something like that. That's what in future.
If your surgeon and the anesthetist both understand the cardiac physiology, probably yes, you can manage the show. But if your anesthetist is not very well versed with cardiac issues, I would still say that fix cardiac. Because see, the anesthetist has to understand demand supply mismatch. That is the most important thing known to cause the perioperative myocardial injury. And if it happens, see, the surgery would be done within 2 hours time, but if it happens, it has got a lasting effect up to 1 year. You may discharge the patient 7 days later. The patient may have mortality after a month or may have mortality after a year. So the myocardial injury that must be prevented. And that is what was the key point when I talked about the perioperative analgesia. That your analgesia has to be really very, very good. Otherwise, if you just give general anesthesia, you don't give block. I would say, if suppose your patient, you are going for say abdominal surgery first, still you go for GA plus epidural. Have a very good analgesia. Or GA plus facial plane block. Block must be there. That is important.
Thank you, sir.